Good morning, everyone. Myself, Dr. Sunita Gupta from Department of GI Surgery, GB Pant Institute and Maulana Azad Medical College, Delhi University, India. Today, I'll be presenting on minimally invasive radical cholecystectomy with adjacent visceral resection. Minimally invasive radical cholecystectomy is increasingly performed in early gallbladder cancer with superior short-term and non-inferior oncological outcomes, as concluded in various studies. Very few reports have shown its safety and feasibility in gallbladder cancer, which require common bile duct excision. We share our experience about the safety, feasibility, and short-term outcomes of laparoscopic management in gallbladder cancer patients who need adjacent visceral resection. Coming to methods, this was a retrospective analysis of prospectively maintained data in which 11 patients who underwent minimally invasive radical cholecystectomy with adjacent visceral resection were included. Patients with primary or suspected gallbladder cancer with adjacent common bile duct, duodenum, or colon infiltration or associated choledochal cyst were included. Patients who had contraindication to advanced laparoscopic surgery or patients requiring major hepatectomy or vascular reconstruction were excluded from our study. Preoperative assessment include routine hematological investigations, triphagic contrast enhanced CT abdomen, MRCP in case of deranged liver function test or associated biliary radical dilatation, endoscopic ultrasound for assessment of interaortocaval lymph node or vascular involvement, tumor markers like CEA and CA99. Upper GI endoscopy and colonoscopy was done for tumors with suspicious involvement of duodenum or colon on imaging. Preoperative mechanical bowel preparation was done for patients with suspicious colonic involvement. Coming to surgical techniques, staging laparoscopy was done to detect the liver, peritoneal, and omental deposits. In absence of metastatic disease, routine sampling biopsy of the interaortocaval lymph node, that is station 16B1 lymph node, was done. This is the picture following sampling biopsy of the interaortocaval lymph node. Resection of the gallbladder was done along with the anatomical segment 4B and 5 resection. This is the picture showing the resected segment 4B and 5 along with the gallbladder. The lymphadenectomy included unblock removal of the cystic, pericholedochal, retroportal, hilar lymph nodes and lymph nodes along the hepatic artery up to the right of celiac axis. It also included posterior superior pancreaticoduodenal lymph nodes. For tumors with adjacent visceral involvement, for duodenum and colon involvement, surgery was planned according to the extent of infiltration. For tumors with limited infiltration, sleeve duodenectomy or sleeve colectomy was done. For tumors with significant infiltration, distal gastrectomy with proximal duodenectomy, segmental colectomy or right hemicolectomy was done. For tumors with common bile duct infiltration, unblock excision of the common bile duct with bilioenteric reconstruction was done either using hepaticoduodenostomy or hepaticojejunostomy as reconstruction method. For tumors with choledochal cyst, excision of the choledochal cyst with bilioenteric reconstruction was done. This is the picture showing sleeve duodenectomy and this is the colonic sleeve. Coming to results, this is the table showing patient demographics. The total number of cases were 11, out of which 10 patients had primary gallbladder cancer and 1 patient had xanthogranulomatous cholecystitis. Female to male ratio was 10:1. Average age of the patients were 46 years. 7 patients underwent single organ resection, out of which 4 patients had associated choledochal cyst and 3 patients underwent common bile duct excision. 2 patients underwent double organ resection, out of which 1 patient had common bile duct and duodenum involvement and 1 patient had duodenum and colon involvement. 2 patients underwent triple organ resection for CBD, colon and duodenum involvement. This is a table showing perioperative characteristics and outcomes. Mean operative time was 330 minutes. Mean blood loss was 200 milliliter. Post-operative morbidity was seen in 9% of the cases. Mortality rate was 0%. Median hospital stay was 8 with a median ICU stay of 2 days. In post-op histopathological examination, 1 patient had stage 1 tumor, 3 patients had stage 2 tumor, 4 patients had stage 3A tumor and 2 patients had stage 3B tumor. 1 patient had xanthogranulomatous cholecystitis. R0 resection was achieved in 100% of the patients. Median lymph node yield was 11. The median follow-up period was 20 months. The 2 patients had recurrence in follow-up period. None of the patients had post-op port-site recurrence. Coming to discussion, these are the previous studies which reported the laparoscopic radical cholecystectomy with lymphadenectomy with CVD excision. The main indication for CVD excision was either the intraoperatively detected cystic duct margin positivity or cystic duct infiltration. The R0 resection rate was achieved in 100% of the cases. In our series, total number of patients were 11, in which laparoscopic radical cholecystectomy with adjacent visceral resection was done for involvement of the common bile duct, duodenum, or colon, or associated choledochal cyst. R0 resection rate was 100%, and there was recurrence in 2 patients. None of the patients had port side recurrence. Hence, we conclude the minimally invasive approach to gallbladder cancer patients who need extrahepatic adjacent visceral resection was found to be feasible and safe with favorable perioperative and oncological outcomes. Further studies are needed from high volume centers engaged in minimally invasive hepatobiliary surgery. Thank you.